Hey, welcome back, everybody. Time for another episode of Health Talks with Dr. Trinh. The one show, maybe the only show, that tries to make sense of all the noise out there today and give you some real advice on how to live healthier, make your brain healthier, live a healthier life. With the man who embodies it all, Dr. Trinh, the healthiest guy I know.
I'm not sure about being the healthiest guy, Good morning, guys.
Good morning. Good morning. Today, before we launch in and introduce your guests, I gotta just can we take a moment and play something for you here?
Sure.
I just want to, and then we can bring in your. Well, let's announce your guest here. Everybody can see him here. Nizan Friedman, welcome, sir.
Good morning. How are you?
Good. And we're going to talk about what? Remote monitoring of health today here?
Remote patient monitoring. Yeah, we'll get into it.
Okay. Well, I want to get into face-to-face health again here. I know masks continued to be a hot topic issue, but I couldn't help but notice I sent Dr. Trinh something last week. There is a woman here in Orange County. I won't give her any more publicity than that, who's put together an anti-mask coalition. She's actually a associate professor here at Saddleback, and she just thinks masks not only are anti-freedom, they're anti-health. And let me play. This was on CNN last night here. This was angry residents responding at a council meeting in Palm Beach, Florida. And listen to some of the comments that these people say why they don't think people should wear masks. Just listen to this morning. Let's see if I can get this up here. I'm playing this is off of YouTube here.
You literally cannot mandate somebody to wear a mask knowing that that mask is killing people. It literally is killing people. And we the people, are waking up, and we know what citizens' arrest is, because citizens' arrests are already happening, okay? And every single one of you that are obeying the devil's laws are going to be arrested. And you, doctor, are going to be arrested for crimes against humanity.
The problem with humanity today is ignorance, arrogance, and apathy. Keep taking the road of least resistance. Keep listening to the TV brainwashing you from birth.
And they want to throw God's wonderful breathing system out the door. You're all turning your backs on it.
So there you go. God's wonderful breathing system, throwing it out the door, and it's the devil. They're going to start doing citizens' arrests. Is there a health worry about wearing a mask? Where are these people coming from here? Dr. Trinh. He's flabbergasted.
So if masks will kill you,
right,
then we are systematically killing every doctor and nurse in every hospital around the world. The problem with these pseudosciences is that, on the internet, you can Google anything you want.
And get any answer you want.
And you can get any answer that you want. So
I'll put it out to your audience this morning here. Welcome everybody who's joined us again on Facebook. We're talking that masks wasn't the topic today, but I had to bring this up, and we've got an expert in who's going to talk about remote monitoring and get his feeling about this as well. A PhD doctor, not a practicing doctor. Are masks dangerous? Forget about whether you like to wear them. Forget about whether it's your choice whether to wear them. Are masks dangerous? Do people think they're dangerous? I'd love you to join in this morning and give us your comments. Are masks dangerous as we're talking about this? Because that's what it's come to. Not only is it personal freedom, you can't make me, but now it's you're killing me. Crazy. Well, on that note, let's talk about, and it goes to the trust of science in general. So now we're going to talk about remote monitoring and how you monitor a patient's health, which would seem to be a very good benefit here. We don't have to go in and stand in line and get sick with somebody next to you there. There's an opportunity to do this, but it goes back to the trust that you put across with your doctor and with the scientists that are out there. If I don't trust you, I'm not going to talk to you at all anymore here. What do you guys know? Do you think trust in medicine is going down these days?
I would hope not.
That
I think there's always been
that's
a
the
level
most honest answer yet. I mean, all we can do is hope not. Yeah, I mean,
there's always been a level of kind of some skepticism, I think, among some groups of people.
anti-vaccination. Well, I'm not going to take a vaccine, right? Yeah.
And there's this empowerment that people get by being able to search the web for the answer. So maybe there's been a trend towards more skepticism, but I think with more education, the correct type of education, maybe people come to realize that physicians are an important part of managing your own health.
And why do we think that I know as much as you do? Well, you've spent your lives doing this. You've spent endless hours studying this and all the requirements to become. It's not like you just filled out a form and became a doctor.
I did.
Well, wow,
Quick form.
5 minutes. You're a Dr. Trinh. But you know that we discount experts. We discount that because what do you know? I know as much as you do. I read it on the internet.
Well, I think this is actually a perfect segue to remote patient monitoring, because the issue is that people want to take care of themselves. They want to take responsibility for their own health, and that's a good thing. Overall, that's a very good thing.
Right.
But the issue is if you're focusing the attention in the wrong direction, then it could be detrimental.
Right.
If you're going to say, I know more than a doctor does, and manage your own care in that direction, that can be detrimental. So I think that what remote patient monitoring does is it gives people a good direction, a direction that makes sense, that works within the healthcare system rather than working against it.
And I can see a positive. I'll just say one other thing, then I'll let Dr. Trinh jump in here. When my parents were alive, their generation, the World War II generation, blindly followed whatever the doctor did. They went in and they completely because they trusted everybody. They trusted government, they trusted the police, they trusted the parish priest. I mean, everybody, those were positions of authority that you looked up to. And of course, we know what happened with all those categories. Now we're questioning the police. I'm a Catholic. We've questioned priests. We've questioned government. Nobody believes in anything anymore. And I think it's an erosion of trust in so-called experts, where there is an actual movement against expertise, and where we somehow think we know as much as they do because we've got access to a little bit of information here. So talk about that as in the course of this conversation. How should I be involved? Should I be challenging you? Should I be questioning you? Should I be just supplying you every bit of information that I've detailed here? How do I participate in a remote health monitoring healthcare system? What's my role?
The first question I have is, what is remote patient monitoring?
There you go. That's probably
most
better.
Folks have never heard about it and don't know what that is or why it's important.
Okay, so let's go through that then. What is remote healthcare? And then we'll talk about, at some point, what's my role in this? Right.
Sure. So my definition of remote patient monitoring, which you probably won't find on Wikipedia, is that remote patient monitoring.
I'm looking it up right now to make sure you're not telling the truth. Right?
You will only get this on this show.
Okay.
So remote patient monitoring solves the broken feedback loop problem in our healthcare system. And what I mean by that, the analogy I like to draw on is the water temperature analogy in when you're taking a shower. So let's say you go to take a shower. What do? You turn the you turn the knob over to the left. You open up the water, and what do you do next? You take your hand and you feel the temperature of the water, and if it's too hot, then you turn it over, and then the next second you feel the temperature of the water again. If it's too cold, turn it over in the other direction until you find a temperature that is desirable to you, and you step in and take your shower. Now, if you draw the same analogy to what happens when you are trying to manage your blood pressure, here's what happens. You go to the doctor, they take a measurement, blood pressure reading measurement. And based off of that one measurement and the measurement that they took the year before, they are going to give you a treatment plan. They're going to give you medication, and they're going to ask you to come back. It might be in a few months, hopefully not in a year, but at least a few months. Now imagine you were in that shower and you turn the water over and you had no idea what the temperature was. You didn't have a sensor that told you what the temperature was. So you step into the water, and 3 months later, you go and ask your doctor if the temperature was too hot. So that's the problem, is that there's a broken feedback loop with you and your doctor, and there's also a broken feedback loop with understanding what your own metric is for health. So hypertension is one component of remote patient monitoring that's a big one, because you have, you know, 70 or more than 70% of patients over 65 have hypertension.
Wow.
And it's a silent killer. It's called a silent killer because you don't have the sensor to understand what your own blood pressure is.
Yeah, you don't know. There's no way. I can't look at it and say, I think my blood pressure is up today. Or, yeah.
Right. When we're looking at when we're testing water temperature, we have that sensor. We have a temperature sensor in our skin. Throughout our body, we have thousands of them. But when you try to figure out what your blood pressure is, there's no sensor there. And so we have this broken feedback loop just in managing your own care. But then you have the broken feedback loop of your doctor managing your care, because they can only go based off of 1 or 2 data points. You know, the times that you actually go in
and let's talk about that for a second. Dr. Trinh talks about this all the time. Data. You guys are all data driven. And yet, if I understand you correctly, our medicine, particularly for these chronic conditions here, blood pressure or cholesterol levels or other sorts of things, all we're doing is getting a snapshot in time, a momentary glimpse. At this moment, this is my cholesterol. At this moment, this is the temperature of that water here. 5 minutes from now, it may go up or down. So I may get a false reading. I may get an incorrect diagnosis because it's just one data point.
And it's not only that it's incorrect, it's the fact that the reality is your blood pressure fluctuates throughout the day. So it's not just a snapshot of what happened during that day, during that immediate time. The issue is that the doctor can't see how your blood pressure has responded, or what it looks like over the course of a month or 2 months or 3 months. So they can't get a true average. It's impossible.
So real quickly, guys, for you guys on Facebook, what we're talking about when we use the term remote patient monitoring is that we send you home with a blood pressure device, a blood sugar device if you are diabetic, or a weight scale, and you use those devices, and the results of those blood pressure, blood sugar, or your weight gets sent directly to a platform that your doctor can view in between your visits with your doctor, so that it's kind of like Bluetooth, or not necessarily Bluetooth. It gets sent directly, so that in between your office visits, you know, whether it's every 3 months, every 6 months, or once a year with your doctor or your provider will have that data. How's my patient's blood pressure doing as they're checking it? How's my patient's blood sugar doing as they're checking it? You don't personally have to even upload that data yourself. We have technology now through Nizan and his organization to get that data, you know, without you doing any additional work other than checking your blood pressure, checking your sugar, stepping on a scale. That's what we mean when we say remote patient monitoring.
So what's the name of the company? Let's give a plug for Nizan. Is this your technology that you've come up with? Is this a company that you're put together?
Yeah, so we co-founded this company. The name is Tenovi Health. If you go to tenovi.com, you can check it out.
And let's spell that. I'm trying to imagine how you spell that.
Tenovi, Tenovi.
Tenovi, Tenovi Technology. All right, so we can go online. We love to go online, check things
Go
out.
online, check out tenovi.com. And yeah, as you mentioned, the general idea is we have technologies that are cellular enabled, meaning they use the same technologies as your cell phone does for transmitting texts or getting online. And so let's say you have your patient who has congestive heart failure. Your doctor wants you to look at your weight, just measure your weight once a day. And we're going to be looking for fluctuations in weight. So basically, you wake up in the morning, you step on your scale, that's it. That's all you have to do. And so that data gets automatically sent over to our Tenovi platform. The clinician can essentially look at that data. And what we have are automated alerts. So what you would imagine is that it's not very efficient if a clinician or clinician staff is looking at the data the whole time. So we have automated alerts. We set up if your weight, average weight drops by, 2 pounds, then we will notify your doctor and he will set up an appointment with you.
Sudden spike, sudden change. Doctor doesn't have to wait 6 months and forget about you. Oh, yeah, Paul Roberts is coming in here. What was his last chart reading? It was 6 months ago. We pricked his finger and tested his blood. We took his blood pressure, and here's what it was. Let's see what it is today here. Maybe he's got a good day, maybe he's got a bad day. And based on just 2 data points, I'm going to make a decision about pills and treatment and all sorts of stuff. Now I can go back and look at months worth of data. I can actually see charts that when it goes up, when it goes down. It makes so much sense to me. I'll tell you another place, and maybe this is something you're going towards, or maybe this is not part of it. My late aunt passed away a year ago. She was in her 90s. She was never had any children. She lived out in Palm Springs, fiercely independent, tried to live alone, and I was her only caregiver. So I was constantly worried. Nobody would check on her the whole week. She didn't leave. And other than the Meals on Wheels person that brought her food, I don't think anybody even checked to see whether she was alive that morning. And I was worried about her. She was overweight, and she had diabetes, and she had a whole litany of things wrong with her. And I always wondered why we couldn't just have her hooked up to some kind of monitor that would tell us, is she alive? Is she okay? Has she slipped into a coma? All these fears I had, it would seem so natural to, in addition to monitoring her ongoing, she had an underlying weird kind of cancer, Waldenstrom's, it was a blood disease. And so she had to always have her blood tested to see if her white cell count was, I forgot, too low or too high or whatever. Right. Anyway, the whole point of the story is, for an elderly population living alone and isolated, wouldn't this be a dream come true? And it would take the fear off her, because she was always worried, oh, am I dying? Am I okay? She could have some data. Everybody'd be monitoring her remotely. Anything like that?
Super important. One of the main reasons why patients get admitted to the hospital is because physicians have no idea what is going on with our patients in between visits.
Right.
So if I saw you and I saw your blood pressure and your blood sugar, it's a one-time number in a snapshot of time. Mm-hmm. And I tell you to come back and see me in 6 months. I have no clue what's happening in that 6 months. Right?
You could be going downhill dramatically or improving dramatically or staying the same. Yeah.
I don't know if you're going up in your health, if you're going down your health. I have no monitoring capability.
Right.
And so my patient, and our patients end up in the ER 3 months later, and we're like, whoa, what happened? And guess what? They were off on their diet, or they forgot to take their pills. And
yeah, right.
And so that gap of time is what remote patient monitoring fills up, in that we actually get to see what your blood pressure looks like in between that 6 months between doctor's visit. We get to see what your sugar looks like. We get to see what your weight looks like if you're trying to lose weight or if you have congestive heart failure. So your doctor is actively involved, or your medical team is involved in between the visits with the doctor.
Now, let me ask the hard question. Doctors are busy. That you give me 5 minutes. You've programmed, you get paid for 5 minutes, and so you've programmed 5 minutes into your schedule, and then out the door. Are you really going to look at this stuff in between, or only in the 5 minutes that the visit I've been allotted to come before the wizard and tell him my problems here?
Yeah, so I think that's a really good point. And remote patient monitoring is not a new thing. So remote patient monitoring has been around for, let's say, 20 years. The technology has improved, but it's been around and the concept has been around for a long time. What has changed is reimbursement for remote patient monitoring. So starting 2019, CMS, Medicare, started paying doctors a reasonable amount of money, $120 to $160 per patient per month, to do remote patient monitoring. And in 2020, they essentially removed the requirement that the physician needs to do all of the monitoring themselves. The monitoring could be done.
Physician's assistant or something, somebody else who's trained to look at this.
Physician's assistant, clinical staff, including nurses, MAs, medical assistants. And the idea here is the lowest hanging fruit is to start getting data from the patient and to at least have something to look at during the next visit. That's the lowest hanging fruit. But in addition to that, Medicare's requirement is that there needs to be at least 20 minutes of data review by clinical staff or the physician once a month. And so again, when you're looking at this feedback loop, so when you're going from, at best, you know, let's say you have hypertension, you see your doctor, they give you a medication. At best, you're going to hone in on the correct dose within, 3 months. But most likely, in many cases, the doctor never hones in on the correct dose because the feedback duration is so slow. Like if it takes 6 months every time you adjust a medication, you're never going to get to the right dose.
I wish I could tell you how many times, again, my late mother, late father, or late aunt, all three of them have left this earth. But at one time or another, being an only child, I was involved in, actively taking care of all of them. At one point, 3 at once. And I can't tell you how many times the doctor gave him a pill and said, see how this works. It worked bad. It worked really bad. There were side effects. Oh my goodness. And we're rushing back over and they're like, okay, we better stop taking that pill here. Because he had a 5-minute visit, one quick bit of data, maybe there was a blood test drawn or something, and they made a snap decision. Maybe that's a harsh way to put it, but they made a quick decision based on a very limited amount of time and data, and they went to the tried and true answer and didn't work. In fact, it caused problems.
How many times have we seen what's called white coat hypertension?
Yes. Oh, right? I got that. You go into the doctor and I start shaking. Yeah, exactly.
Yeah. and you walk in, and I see it all the time, and the patient's blood pressure is super high, and then my patient would say, doctor, it's normally normal at home, and I'm looking at the blood pressure now, and it's like, it looks pretty high now. What decision do I make? Do I make a prescription based on your blood pressure now, or do I make a decision based on what your blood pressure is like at home most of the time? Mm-hmm. So remote patient monitoring allows us to make better decisions because we get to see what these numbers are every day when the patient's not in the doctor's office.
And you're actually going to get compensated for some of the time, so I have a little higher trust that the doctor is really going to carry through, or somebody in his staff's going to look at this data. It's not just going to go in the trash here. Somebody put Ann wrote on here, good morning all. My mom has a pacemaker that I can't read. It's a little machine that constantly transmits the data. We're such a smart people. Why can't we extend this and do more things like this? Does your device, or are there other devices that monitor your heart rhythms? If I have a pacemaker?
Yeah, so pacemakers are obviously an invasive device. Right. And so in general, the field has tended towards non-invasive devices, towards monitoring certain types of data. There are continuous blood glucose meters. There are continuous meters that are invasive.
Something gets implanted, you mean, in me, and then does the monitor something internally?
Correct,
heart or whatever.
but the reality is that the majority of people don't need an invasive meter. They need something equivalent of stepping on a scale in the morning. So that, if you ask, the majority of the population, would you like us to inject you with this device?
This
They're
chip,
gonna say,
yeah.
This chip, they're going to say no. There'll be some that say sure, why not? But the majority will say no. And so what we need is something where the barrier to compliance is so low that they actually do it. And the way that you do that is you remove all of the barriers of syncing up the data with your phone, hooking up to Wi-Fi. You don't need to do any of that. You basically need to do the equivalent of just stepping on the scale. And that's, from the patient's perspective, that's all they need to do.
So is the scale it's not Bluetooth, it's actually cellular enabled. It's going to use a cell phone tower. Is it the scale that sends the info and gives a reading? Is it what other things? We got a scale. What other things can you hook up to?
There's blood pressure.
Blood pressure. So you put a cuff on and it sends the data or something. Yeah.
Yeah, and I think
sugar.
Yeah, blood glucose.
How would you do that? You'd prick your finger or something, and then what?
Equivalent to what you would typically do for measuring blood glucose. You have a test. You have a strip. You put a dab of blood on there, and then you stick it into.
Oh, you stick it into a machine, right? Okay.
And it will read it and send it over.
Got it.
So I think one important distinction here to make is that we're not sending over a kit of 10 devices. We're sending over one device that is tailored to what the doctor is trying to, the clinical endpoint that the doctor is trying to achieve. So if you have hypertension, we're not going to send over a scale. If you have hypertension, we're going to send over a blood pressure monitor. If you have diabetes, we're going to send over a blood glucose meter. If you have congestive heart failure, we're going to send over a scale. So it depends on what the patient has, the condition, the chronic condition that the patient has.
So it's not a one-size-fit-all. Here, you take this kit and measures 20 things, even though you only need 2 of them.
Right, because the patient would never do that, and so that's one of the issue with the kit idea, because of course, it's from a doctor's perspective, it's always better to get more data, different clinical endpoints, but you need to factor in patient compliance, and one device that is most pertinent to the chronic condition makes the most sense.
One of your other people on here said, "I'm with you, doctor. Going to the doctor scares the crap out of me." Me too. All right, so let's talk through some of the. It makes so much sense to me. I'm a sensible guy. I'm in a sensible mood. It doesn't seem scary at all. Particularly because I'm participating, I'm buying into this, I'm choosing to do this, I'm an active participant, I'm going to take the test, I'm going to step on the scale, and the minute I do it, I know I'm sending data somewhere here. Yet, it goes back to the thing I first started. I don't want to start a Donnybrook or get people doubting this, because it makes so much sense to me. But there are those, as you alluded to, it's Big Brother. Don't monitor me. Don't check on me. I'm not doing anything because I don't trust you with that data. I don't trust that someone's going to read it, maybe, or probably more likely, I don't trust that you're going to keep it private. The HIPAA Act and all that stuff here. This stuff's going to get out. My employer is going to know I got high blood pressure and they're going to fire me or something, or they're going to know I've got, I don't know, something scary, and they're going to, somehow this is going to impact me. Talk about that. How do you create, because we go back to trust again here. Do I trust my doctor? Do I trust the science? Or is it going back to my grandmother's era, who every time she was overweight, she had heart conditions, and every time we'd say, have you gone to the doctor? She'd go, what do they know?
So these processes go through HIPAA compliance, obviously.
Which means they're protected, that they have standards, right? Yeah. And if it does get leaked or hacked, the doctor has a responsibility to notify you that the data somehow.
So the question that should be asked is, do you trust not having that data to your doctor and your doctor not knowing what your data looks like
Yeah.
within the 6 months that you see your doctor?
That's an right. So will you trust the doctor's diagnosis without that data?
Without that data? Um, and Jody, to your point, with remote patient monitoring, you don't now. So what we do now is we tell our patients to write down your blood pressure, write down your heart rate, or write down your sugar, and send that in to us, every 3 months, every 6 months, or bring it in to us with your next visit, so that we can review. So essentially, that's patient monitoring, but that's extra work on the patient to collect that data, to write everything down, and then to send it in to their doctor. Remote patient monitoring basically utilizes technology.
Because we're lazy. I don't know. Am I going to write it all down? Am I going
You
to
don't
do
have
it?
to write anything down anymore.
One of your comments is I think that's what she's saying, is getting me to comply with your request. Please, Paul, would you give me a state? Yeah. I meant to, but got busy, Doc. Come on. I got a life here.
Compliance is hard, Sunshine. Sunshine's mentioning that.
Right.
Getting someone to test their own pressure or sugar. Yeah, so compliance really is a conversation. And
so it's designed to be convenient to me. This isn't scary. I'm not trying to be invasive. We have a technology. If you really want to give your doctor better advice so you get a better diagnosis, then take advantage of this and just do the work. All you got to do is step on the scale, prick your finger, and this technology will do the rest. It'll track it. It'll send it in. And the doctor doesn't have to wait 6 months to sit there and look at it and say, what's this chart showing here?
Well, I think the other important point to make is that the doctor is half of the equation, and you're the other half.
Right.
And so when we're talking about the feedback loop, you are now giving yourself access to your own blood pressure, and I think this is a very important point, because people do want to manage their own health. Yeah. And there's many who do, and they should. And so let's say you're in a situation where you habitually look at your blood pressure. You will notice that there are some days that your blood pressure is higher than others, and you can reflect on that. You can say, this day I was much more stressed out. Or you can see that from May to June, my blood pressure went up on average by 5% or 10%. Now, these are things that you wouldn't be able to typically notice, but these increases or decreases, these are things that can help you manage your own health. If you notice that your own blood pressure is going up, and you want to manage your own health, the obvious thing here is to diet, to exercise more, and hopefully this habitual process of understanding your own data will lead to better outcomes for yourself, but managing your own health.
So we're talking with Health Talks with Dr. Trinh. We're talking to Nizan Friedman. The name of the company again is?
Tenovi.
Tenovi. T-I or T-E?
T-E-N-O-V-I.
T-E-N-O-V-I. What does that mean? Well, how did we come up with Tenovi?
So Tenovi Health roughly translates to your new health in Latin. So Te Novi, it's roughly
Novi, yeah, new. I should know that. I'm an Irish Catholic. I studied Latin too many years. Oh my goodness, I missed that here. I can't believe my Latin didn't pick up, because te means you, and novi means, it's sort of like a new you.
Yeah, that's right.
Okay, all right.
The entire reason Medicare is pushing this, promoting it, and paying for it is because Medicare believes that if we can remotely monitor vital signs and blood pressure and blood sugar in between your doctor's visit and know in real time what your numbers look like, we can decrease your visits to the emergency room.
Yeah, and get better diagnosis.
Immediately. Yeah.
get better diagnosis. Again, I can't tell you the number of times they gave a pill, gave an idea, and it was bad. It didn't help. It hurt because they're
Yeah,
guessing.
And again, this is not a new concept. The National Institutes of Health has funded multiple studies for many years looking at the effect of remote patient monitoring on a patient's health. And Medicare, CMS in 2016 did a meta-analysis, which is they essentially looked at literature across the board for congestive heart failure, hypertension, diabetes, and so forth, with studies that did remote patient monitoring. 55,000 patient study, right? They meta-analysis. And what they found was an overwhelming positive outcome. They saw improvement in cost savings for healthcare systems, but then they also saw things like 55% reduction in hypertension for patients who underwent remote patient monitoring programs.
55% reduction, half?
Exactly. They saw 40% reduction in 30-day hospital readmissions. When you discharge a patient and you have them on remote patient monitoring, they reduce hospital readmissions by 40%.
Well, how would that help? Just because we know we can catch something quicker or something?
Yes.
Exactly. It's that simple. I mean,
Proactive.
you're being proactive. You're finally practicing preventative medicine. You're not waiting until the next heart attack or stroke happens. If the blood pressure spikes, if it's above 200, you're going to call that patient and manage that patient before something critical happens.
Wow,
So
that's huge to prevent. Well, that's the goal. That's the dream. We want to prevent the heart attack, prevent the stroke, prevent the giant occurrence that the whole medical system is made to take care of. That we've got these massive machines and massive budgets and massive training, so they can go in and give you a new heart. They can replace your lung. They can, hooray! But can't we get to a point where we can prevent the need for all of that?
This is exactly the benefit of being able to see your patient's information in real time without waiting 3 months later to visit when your patient comes back. Heart attacks occur when blood pressure is out of control. Stroke occurs when health conditions are out of control because the doctor is not actively monitoring those vital signs, right? Diabetes go out of control because we have no clue what your blood sugar looks like in the last 6 months between the last visit.
Right. And
So
that leads to a
preventing-
major thing. Now, I'm going to be really, you're going to hate me for this one, but aren't you working against yourself? You guys want me to have a heart attack because you get $3 million when I get a heart attack. You only get 3 cents when you monitor my symptoms. Come on, it's all about money.
Yeah, the systems get a little kind of backwards sometimes, but I believe we are moving in the last few years in a new direction.
Well, certainly Medicare doesn't want to see you have a heart attack because they don't want to pay $3 million to this. They'd much rather, they're really incentivized to reduce, in fact, they penalize hospitals now, don't they? If you have a return visit within 30 days, they're like, oh, you didn't get it. You weren't fixing it. So they're all about controlling costs, which means keeping major occurrences from happening, major surgeries from happening.
And that occurs with remote patient monitoring because we see in real time and we become proactive in real time without waiting for our patients to land in the ER for their out of control, whatever.
Right. All right. So let's ask a question of your audience here again. Let's get their participation and be honest here. Do you really, would you embrace this kind of technology? Would you welcome the data? Because I assume the patient has access to this data too. They can chart it and see what's happening here. Do you want to know or don't you want to know? I'm one of those aging baby boomer men. Part of me doesn't want to know. If I don't know, I'm not sick. If you tell me, then I'll worry about it. So I'll just kind of pretend everything's okay, and I'll ignore those signs, and I'm not going to go see the doctor because I really don't want to know. Is there anybody else out there like me? Or do we all want to know? Many others. My father was one. My late father was one. He tracked everything. One of the people wrote in here that he kept a daily chart of all his vitals. My aunt did the same thing. She always demanded to get a copy of her blood work and everything, and she kept it in a file. Not that she knew much about it, but she would see, am I going up? She was looking for trend lines. Am I going up? Am I going down? Am I getting better? Am I getting worse? I don't know what all these things are. What am I supposed to be? I'm supposed to be 8 or under, and I'm 9. I don't even know what this is, but I'm 9. That's not good. I want to see if it's 10 next time here. And then I'm going to ask the doctor about it. Hey, my turretine level or some crazy thing here.
Those are the engineers.
Yeah, right. And so they wanted to, because they felt like they wanted to have some control over it. And I'll tell you the other reason both of them like to have control over it. I hate, again, to pick on doctors here, because doctors make mistakes. Hey, doc, didn't you notice that this thing has been spiking for a while here? Oh, yeah, no, I didn't look at that. Thanks. Didn't you see that we tried something 6 months ago here and it didn't work? You know, I'm just reminding. I know you're busy. I know you got 5 minutes. You're human. You just saw 400 patients. Focus, doc. Let's look at this. What about this thing here?
Yeah, so Isabel wants to know, Lawton Tess wants to know, Jody wants to know, but refused to be patient shame. She needs a partner, not a mean boss.
Oh,
I love that, Jody.
Yeah,
Yes,
right.
yes. Your healthcare should be in partnership and collaboration.
That's a good point, because if you make me feel like a little kid, then I'm not going to tell you anymore.
That's right. It should be in partnership and collaboration with your medical team. Yeah, the old days of a physician having this godlike complex.
Dr. Welby, that old
gone. Yeah. That should be gone.
Yeah.
Should
This
be gone.
old guy who's going to tell you, no, come on now, come on, Dr. Trinh, come on, Nizan, you're not living up, you're not doing your part here now. Come on now, get with it.
Well, I think the important thing to realize here is that remote patient monitoring is more for the patient. It's more for you as a patient than it is for your doctor. The question is whether or not you want to have the right medication. If you're taking medication, do you want to be taking the right medication? And if the answer is yes, then you want to give your doctor, you want to give the doctor, the person who's prescribing that medication, the right information. If he's going to be basing your medication off of incomplete data, then there's a good chance he's not giving you the right medication.
So
that's a question for you as a patient and whether you want to, how important that is for you.
So one of your, I think Sunshine here said the same thing. She admitted, I'm not the only man out there. Why are men so lousy? She said her husband ignores his health. He ignores the signs. We're supermen. We're tough. Part of it's macho. We're going to keep going. And part of it is we're little kids and we're scared and we don't want to know. It's the same reason I don't take my car in to get fixed. The minute they take it in, they find something wrong. And then they start opening it up and everything gets worse. I do better just to keep driving the car.
Ignorance is bliss.
Ignorance is bliss.
Right.
Can't be sick if you don't know you're sick, then you can't be sick. But I know that's stupid. That's childish. But I hate to say it. I sort of feel that way.
So the data's out there, right? We know that if you have high blood pressure, you have 3 times higher chance of getting a stroke or a heart attack.
Say that again. Say that again. You just throw these stats out so quickly here.
If you have high blood pressure,
right,
hypertension, you have 3 times higher chance of getting a stroke or a heart attack.
Wow.
I wouldn't bet. I wouldn't go to Vegas and bet on that. Yeah, that's not a good bet.
So it's a question of whether you want to ignore it.
Yeah.
If you know that you have it, right, then it serves you well to not get a heart attack or stroke by just taking the right medication or making a lifestyle change. And so I think
lifestyle changes so much. We talked about that time, eating better and doing better. That's the hard one. I want you to give me a pill and I'll make it go away, but I'm going to keep smoking. I'm going to keep eating fried food. I'm going to keep not exercising, but keep me alive, Doc.
Completely. And you know, from our perspective, the lowest hanging fruit is just giving better data back to the doctor so that he can give you better medication. That's the lowest hanging fruit. But the more difficult thing would be a lifestyle change. And I would imagine that some individuals who habitually take their blood pressure and are involved in this program, they're more mindful. They'll become more mindful of what they're eating, or they'll become more mindful of how often they're exercising.
Yeah.
It might not happen for everybody, but even those who do not make any lifestyle changes, just getting better access to better medication tailored to them, I think will make a huge difference.
So again, go ahead.
Remote patient monitoring doesn't have to be about changing your meds. It is about changing your lifestyle. Because if I notice your blood pressure is high, I may want to ask, what are you eating? Right? What's your diet like? How can I, do you need to exercise more? It is completely about lifestyle changes. Changing your medicine is just one tool we have, one component, but then a physician will know exactly what's going on, because they'll ask questions, right? If your sugar is high, what are you eating? What's your diet like? And what can we do to adjust that? In between that patient visit every 6 months, every 3 months, we can be proactive now to make those decisions with lifestyle change.
Again, somebody, so let's talk through just quickly, we've 100 benefits to this. Come on, I know you guys just shaking your heads going, why isn't everybody just embracing it? Medicare gets it, it works, you get more data, you make better decisions, you have some control over your life. It isn't just once in a while you get a test and you flip a coin and say, let's see if this pill will work. I get it. So why is it slowly adopting? One of your people said on here, hey, I've had 3 appointments for remote monitoring. I don't know whether anybody's looking at this. Am I just sending data into the Ethernet here? How do because I don't see anybody looking at it. Nobody responds to me, says, got it, checked it, good, we're on it. It's just, I'm trusting again that the system is doing this. Talk about trust.
This is the reason why Medicare has, as part of the reimbursement, a mandate to do 20 minutes of data review that includes interaction with the patient. So it's not good enough. It's not good enough to just look at the data, because like you mentioned, we don't know, the patient doesn't know who's looking at the data.
Right.
They don't. So the important part here is the interaction with the patient.
Feedback loop. You're talking about a feedback loop. I gave you data, give me some feedback. Right.
Exactly. And so that has to happen at least once a month. For that individual who's 3 months into an RPM program and they haven't been contacted, well, they're not following the correct protocol. And so I would recommend choosing a different remote patient monitoring program.
Yeah, right. So there you go. So now I know that I have the power of the federal government is checking, and you want your money, I make sure you communicate with the patient here. And if you're not hearing back, that empowers me to go make a better decision. As somebody said, if I'm not part of the team, then I ain't playing.
Completely. And there needs to be that type of feedback. Otherwise, the patient is just left blind, just hoping that they're doing a good job. I mean, there has to be that feedback. It's very important.
So would we ever get to a point, and I know the answer is no, where we could, and I know there's 100 reasons, they're going to explode right now. Big brother, don't track me, don't put a chip in me. But by God, if we all did have a chip in us, we'd all know a lot more about what's going on. We'd all know if we have coronavirus right now here. We would just turn our thing on, oh, I haven't got it, okay. But we're so frightened to give any, to surrender any privacy data. And yet we go on the internet freely, Facebook, Twitter, LinkedIn, and if anybody's ever noticed, when you sign up for those services, you sign away your life. That data is theirs. You're just randomly telling them what I'm buying, who I'm talking about, what I'm interested in, everything there, blah, 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 and we don't think twice about it. And they make trillions, not just selling us the service, they make trillions selling that data to everybody who wants to know what's Paul eating, where did he go, what's he thinking, who's he interacting with. We surrender that data so willingly, and yet when it comes to our own health, we're so frightened to surrender any of that data to anybody. I don't know why.
As long as the chip's not on your right hand or your forehead, it says 666.
Right, that's what we think. It's Big Brother. You're gonna put the chip.
So,
Anyway, well, I'd be one that I would take the chip. Like I would. Last question: would anybody take a chip? I'd willingly put a chip. You can know anything you want to know. There's nothing top secret about me. I don't know what the hell you do with any of it. Go ahead, sell it to the world. I really don't care. I'd much rather know all that data. I don't mind when they suggest things to me. Hey, you're looking at this. Here's something else you might want to buy. Okay, good, thanks.
I don't think we need a chip to check your blood pressure, check your weight or your blood sugar with all this. But the whole goal of this really is so that your doctor and you can collaborate on a monthly basis,
Right.
On how your blood pressure is doing, how your sugar is doing, how your weight's doing, rather than waiting every 6 months to talk to your doctor.
And
the
get
whole
one
reason
little
for this
piece of data.
collaboration-
Yeah, one little
right,
piece
the whole
of data.
reason for this collaboration is prevention.
Okay, so every last question: would anybody not do this? I'm trying to go through all the negatives. What's keeping this from massive adoption here? Is it cost? Is it nobody's aware of it? Is it I'm not sure I like it or understand it? What's key? Why aren't we all doing this right now?
Well, as I mentioned, CMS opened up these codes 16 months ago, 18 months ago.
CMS is who? What? Medicare?
Medicare, sorry.
Okay.
And so before this, there were some other remote patient monitoring like codes, but they were too difficult or onerous for the physician on the physician side.
Okay.
So where this all starts is education on the physician side, where they understand this isn't a lot of extra work for me as a physician, because as you mentioned, physicians, they're ready. The main issue with physicians' time is that Medicare and other insurance companies, they're only paying a certain amount of money
Right.
per session. And so in order to make the salary that they want, desired salary for a physician, they need to see a lot of patients.
Right.
And over time, what's happened is insurance companies have said, oh, looks like you're doing a really good job. Maybe we're going to reduce the amount that we pay you so that you can do an even more efficient job. It's equivalent to, if I had a sales rep that made $1 million last year, and I said, you did a great job, but let me cut your commission down by half.
Right.
That way you can call twice as many twice as many people. But guess what? The quality of care goes down.
Yeah.
So anyways, that's a rant on why.
And I'd love to do a show on that, Dr. Trinh. I think the quality of care has gone down. I don't have any proof of this. This is just me. Again, I'm anecdotal, and my opinion is as good as science in my mind here. But I don't know how, as they see more and more patients and the time you spend with the patient is shorter and shorter, how that can't affect the quality of the diagnosis. Maybe this is a way to counteract that, because you're getting data. They can work it into their schedule and find other times to look at this, or they can pass it off to other trained people. More and more of the physician's assistant seems to be doing a lot of the work anyway, and you only get to see the doctor for the really serious stuff here. Whatever it is, I just question, as we compress the time spent, as they get paid for less, as they spend less time with you, are we really getting the maximum care? I don't know how you can instantly make these snap judgments all day long and then change your mind. Okay, now 5 minutes later, I'm looking at somebody else. What's your chart? Do this. I
agree. The average, and this is noted on national surveys, the average primary care physician spends 7 minutes with their patient.
And on that hinges their whole decision in 7 minutes.
And all their decisions is made in 7 minutes.
And 5 of that, they're asking me a question or filling out a form. There's a 2 minutes of a thought process. Try this.
And so I don't even know how you get, education on prevention into these 7 minutes when you're just busy on, writing prescriptions, refilling meds, putting in referrals, putting in consultation notes, and typing your notes as you're talking with your patient now. Right?
Yeah, right. My aunt's doctor used to start typing the minute, or he would dictate it. Saw so-and-so, looks fine. He's dictating the whole thing. She's like, hello, I'm over here. You haven't even talked to me yet here. But he's already halfway through the form before he's asked her first question. Ann says, same thing I feel. I love my doctor. as he gave me less and less time, I left.
Yeah, I don't blame you, Jody. And this is partially why doctors are leaving groups to do this, I don't know, concierge thing or
Yeah,
VIP
right.
thing where they're only
Unlimited,
taking a
yeah.
limited number of patients. And
You
they're
pay me a
spending
set
time.
fee, your win, lose, or draw, and then you get to see me for long periods of time here. Yeah.
Yes, it's.
Well, I wish we had more time to talk about this, but we don't. So let's give everybody the let's go be proactive. Sunshine says she'll take the chip. You and me, Sunshine, we're signing up. Give me the chip. Tell me everything. I want to know it all.
You're so funny, Sunshine.
Dr. Nizan Friedman with Tenovi. Now it's Latin. It's in my head. You knew the new you.
Your new health.
Yeah, right. Okay, and is this coming to a doctor near you? I don't know. Should we go ask our doctor? Hey, you got a telemedicine? You got a remote monitoring opportunity for me, doc? Here, maybe it's something we need to be pushing them, and they go, God, we could look into this. 5 people asked me today.
Well, it goes in both directions. So you as a patient, if you're interested in this, by the way, with the COVID situation, there's a waiver on your copay for remote patient monitoring, so it's completely free for you.
There you
as
go.
A patient.
Incentive. We're building incentives into the system
Completely.
here.
And so it can go in both directions. You as a patient can say, I would like to be on a remote patient monitoring program. Here's a company, Tenovi, that does a really good job. Or it's possible that your physician in the next few months will approach you. It may go in either direction.
I got to leave it at there. Thanks so much for joining us today here. And come back next week as we talk more health talks with Dr. Trinh about new and exciting ideas like remote healthcare monitoring.